Okay, madam, we are live.
Yeah, hi. Welcome to this masterclass session number 2. And yesterday we spoke about a very basic topic, and today we are talking about again the extension of a similar thing. We were talking about molecular level yesterday, but today we will be talking about the mechanism of fibrosis in adenomyosis and endometriosis. So fibrosis is again like one of the toughest to deal with, when especially when we are dealing with pelvic surgeries involving endometriosis and even adenomyosis. So people who are actually doing the surgeries, maybe like open or even laparoscopy, they will realize as to how much the fibrosis in such diseases, and the tactile sensation is so important when we are actually doing it. But today, rather than the surgical aspects, I think we will be dealing with the basic aspect of this disease, which has become more and more prevalent now. We don't know the reason as to why the incidence is increased so much, whether it is lifestyle, whether it is something else, genetics, we don't know. So today, I expect Dr. Jay to throw some light on the aspect of fibrosis and how the tissue actually changes in these diseases. Yes, over to you.
Yeah. Thank you. And hi. So guys, try and understand. Yesterday we spoke of the entire molecular signature. Okay. I will speak for only 10 minutes about why fibrosis occurs. Because if you understand the concept of fibrosis, you will realize fibrosis is typically associated with deep endometriosis. That means when we try to call something and when we try to say, oh, there is a nodule, that nodule basically signifies that there is fibrosis at that region. Okay. And fibrosis is just like any other fibrosis. Okay. So I will go to the screen sharing again. And once I go to the screen sharing, you can see the screen, right?
Yeah.
Okay. See, what is very important for us to understand is that whenever we talk of fibrosis and endometriosis, it is going to occur at all the abnormal locations. And what do we try to do? We try to give medical management because there is fibrosis and because there is fibrosis associated pain. And we try to somehow fix it, of course, wrongly, in the head of the patient that, oh, this medication is going to go and work wonders over your fibrosis. No need to excise. No need to do any surgery. Go ahead and do IVF, even if there is presence of deep endometriosis. Fortunately, there is no evidence now. Papers have come and they've completely changed what we were thinking before. Okay. And I'm going to touch every aspect of that so that we understand. Okay. So now this is our endometriosis. This is going to be adenomyosis, which is going to be present here. And this is going to be the deep endometriosis, predominantly the uterosacral region and then invading inside the rectum. Okay. If I just magnify this entire picture, for us, you will understand that histopathology report is going to talk of many stromal cells. And along with the stromal cells, the histopathology report is going to talk of course, fibrosis. Okay. This is how the histopathology report is going to come. Now, this stromal cells, as we studied in the class yesterday, is of course going to have estradiol beta. It is going to have reduced level of progesterone resistance, progesterone receptors, and extremely reduced levels of estradiol alpha. And simultaneously, it will also produce PGE2 in excessive quantities. We all know that for somebody to grow in life, they are going to require blood. So there is going to be a lot of neoangiogenesis, which is going to occur inside these nodules. Okay, this neoangiogenesis is partly played a role by something called as vascular endothelial growth factor, that is VEGF. And as a result of this, in between, people experimented with a beautiful drug called cabergoline, because cabergoline is a VEGF inhibitor, and people thought that, okay, you block the vascularity and endometriosis will subside. But nothing like that happened, because this is only going to block the vascularity in a new nodule. The nodule which has already formed is already formed. Okay. So what happens is, when this nodule is growing in size, when these Estradioles, when these endometriotic cells are now growing in size, no, they are also developing vascularity in between them. Now, sometimes the growth is disproportionate, and as a result of this, one of these blood vessels is going to break. When this blood vessel breaks, there is going to be leakage of blood, which is going to happen. Whenever there is leakage of blood, which happens, okay, immediate reaction of the body is to make sure that body deposits something called fibrin in order to clot it and occur fibrosis. Now, this fibrin which is formed is slightly atypical as far as endometriosis is concerned. And because of this atypical fibrin, multiple such small hemorrhages will give rise to area of fibrosis. And this fibrosis which has occurred is now free of estrogen. It is free of progesterone. It is free of blood vessels. It is free of vascular endothelial growth factors. It is free of estrogen alpha. Basically, it is free of any receptors. And as a result of this, whenever a deep endometriotic nodule is formed, nodule is basically your patch of fibrosis. Nodule is going to be free of receptors, and as a result of this, your wonder drug Dynogest, which is completely receptor dependent, your wonder molecules GnRH agonist, which are completely dependent on down regulation of receptors, your oral contraceptive pills, which will again go and down regulate the receptors, and again the new sweet boy in the town, elagolix, which is a GnRH antagonist, as we studied in the previous class. Nobody will go and act on the nodule, because the nodule has no receptors. It is predominantly got fibrin, and even if you inject Dynogest inside the nodule, because it is purely fibrotic without any receptors, nothing is going to work on that. This is the concept of a deep nodule, and a reason why no matter what drug you give, the nodule does not disappear. The drug prevents formation of a new nodule, but the nodule which is already present is never going to disappear. And as a result of this, we keep on telling people that surgical excision, after you do surgical excision, you may give maintenance in the form of oral contraceptive pills. That is different. But surgical excision plays a role whenever there is fibrin formation. Now, there comes another concept here. Okay, all this is fine, but what if there is any such tissue which has occurred in the ovary? All right. And this is going to be mind blowing, because if you study why ovarian endometriosis occurs, okay, then it is really going to help you understand how to treat an endometrioma from here onwards. Okay. So I will just delete the vagina bladder, let all that go. Okay. Now I've drawn cervix, I've drawn uterus, I've drawn fallopian tubes on both the sides, and I've drawn both the ovaries. Okay. Now, what typically happens? Sometimes there is a altered endometriosis tissue on the surface, which is the most common. Most common, when I say it, is more than 95% of the situations. And sometimes there is ovarian endometriosis occurring from within the cortex. That is different. This is only 5%. Whenever it occurs within the cortex, it forms an endometriotic cyst, which is beautifully walled off by the layers of the cortex, and this cyst becomes easy for us to dissect. Why does not have fibrin formation should be the obvious question which people are going to ask. The reason why it does not have fibrin formation is because, like any other cyst, there is space to expand inside this. That is the reason you will see it forms an endometriotic cyst. Okay. And you will have some endometriotic cyst. We have all operated these patients where we found inside there was only endometriotic cyst, and there was only so minimal adhesion inside. Nahin? Very little adhesion was present inside that endometriotic cyst. This endometriotic cyst constitutes the 5% category where enough space is available. No fibrin formation occurs, because even if the blood vessel leaks inside, it can form altered blood because of prolonged presence. No need to form fibrin, because there is lot of space available. So fibrin is not required only. And this gives rise to the brown colored chocolate colored fluid, which gives rise to the formation of chocolate cyst. Correct. Same thing happens when you have surface endometriosis. When you have surface endometriosis, there will be some bleeding, little bleeding happened. But bowel is very close by. Sigmoid is watching. So sigmoid came, are, little bleeding ovary, I'll come to help you, don't worry. Sigmoid comes and walls off that blood. Okay. So that ovarian endometriosis gets covered by sigmoid colon, and our MRI and CT scan and ultrasound will typically report dense bowel adhesion. Okay, this bowel had no role to go. Why did the bowel not go and get adherent in dermoid cyst? Why did the bowel not go and get adherent in serous cyst? Because all of them are intra-ovarian pathologies. Understanding? Endometriosis is one condition where it is a surface pathology also in most of the situations due to exophytic growth. This then causes walling off, and then this exophytic part becomes the endometriotic cyst, which is filled with chocolate colored fluid. As a result of this, when you are doing surgery, you would have noticed simply with your suction cannula, when you try to do like normal adhesiolysis, many a times the chocolate colored cyst will simply break apart and it will give rise to chocolate colored discharge, which will soil the entire peritoneum. That is predominantly going to happen in an exophytic cyst, which is the 95% configuration in ovarian endometriosis. And in ovarian endometriosis, fibrin formation occurs very much more on the surface of the walling of lesion. That means when sigmoid come to wall off, sigmoid has no space. So that causes walling off over the sigmoid, and it causes fibrin deposition over that sigmoid and nothing on the ovary. As a result of this, many times when we are doing this entire dissection in endometriosis, we come to a sort of a conclusion that, why this ovary was so good and why the bowel was so bad. Okay. And the reason is the angiogenesis and the fibrin formation and the availability of space. So the obvious question is, why do you think there is availability of space in the ovary and no availability of space on the rectum? Guys, remember, once two tissues wall off, no, it is not like a 2D walling off, which occurs in the body. Body will wall off everything in 3D. So there is a pocket which is formed with an endometriotic tissue. And this pocket keeps on getting bigger, and keeps on getting more fibrotic. When it gets more fibrotic, you will have nodule formation. And this is predominantly the reason where you use the word deep endometriosis, because it is deep in the pelvis, no space available to grow. Nodule formation is very high, especially in rectum, uterosacral, parametrium, nerves, paracolic region, everywhere, where you have a lot of space available for things to grow. Ovary, peritoneum, fallopian tubes, lateral pelvic wall. In all this situation, you will have more of cyst formation, okay, as compared to nodule formation. Just keep this concept in mind because so much space is available. One more place where you can actually have good amount of cyst formation and very little amount of nodule formation is going to occur in extrapelvic locations, especially the abdominal wall. In abdominal wall endometriosis, so many times when you chop off the abdominal wall lesion, you will see brown colored tissue, fatty tissue, and you will also see stromal tissue giving out chocolate fluid from there, isn't it? This is predominantly because the abdominal wall has given some space for it to grow. But when the abdominal wall endometriosis invades the same rectus muscle, it is pure stone. And that pure stone is because the muscle has no space to grow. This concept of understanding why nodule becomes like this is going to help you understand that now when you see a nodule in a patient who is having IVF, remember, even if you give decapeptyl depot, agonist depot, lupride depot, whatever depot you give, nothing will happen to the nodule. Nodule will stay as it is. Uterus will stay as retroverted as it wants to stay. And because of this nodule and peripheral region secreting high PGE2, you will have multiple IVF failures in patients with deep endometriosis. Good papers have come out from Europe, and these days, even I have got into the fancy of publishing because we have kept a team for this, and we have documented, we are trying to publish it, where the minute you remove it, previous IVF cycle with deep endometriosis, the minute you remove the bowel nodule and do one more IVF cycle from the same consultant or from us, the success rate of IVF will go up because uterine anatomy comes back to normal, uterine contractions reduce, and the patient experiences clinical pregnancy rates. Okay, so with this, I conclude this basic aspect of fibrin formation and drug and some practical coverage with that, and I'll be happy to answer 2 or 3 questions.
So basically, you're saying that like even for deep endometriosis, don't give any medical management. Directly the surgery is the option, especially if there is a fertility issue.
Correct.
Isn't it? Yeah. So, but you see, I mean, there are some people who tend to have this deep endometriosis with so much of fibrosis.
Yeah.
And there are some people who, like, I mean, don't have this problem. And like majority of them, 90% of them will have IVF failures, as we have seen in our practice.
Yeah.
10% can still conceive even if they have not been operated.
Yeah. That is because of I explained even yesterday. All this is because of high concentration of PGE2. PGE2 any which way stimulates uterine contractility. But PGE2 is very polymorphic. That is the reason you don't know how much PGE2 is required in a particular woman to make that uterus contract.
Yeah.
Right? And
also,
that is the reason why some people conceive despite extensive endometriosis. Some people have minimal peritoneal endometriosis and have no conception.
Yeah. Where did you go?
No, I'm right here.
Okay. Yeah, sorry. So I think like when we are talking about deep endometriosis, fibrosis, see, the relevance of it is first is like how you plan your mode of treatment, whether medical management or whether you want to choose the surgical option as the first line. The second thing is if you are a surgeon, if you are a laparoscopist.
I'm sorry, ma'am. I wanted to add something. Sorry. Madam mentioned how do you want to plan treatment. If you are a basic ultrasound guy like me, remember areas which appear to be hypoechoic, black, kala, is basically fibrosis, nodules. Understanding? There will be minimal vascularity inside them, but there will be nothing else. Cyst and appearance of an active lesion is going to be completely different ground glass appearance. But nodules are identified as a hypoechoic spot. Okay, sorry. Ma'am, you can continue.
So then coming to the dissection part, like how do we dissect it and all that. So we see that like the fibrosis, what we see in endometriosis, especially in fresh cases, is very different from the fibrosis which happens post-surgery, the adhesions especially. So we see that the rectum sigmoid is adherent to the posterior wall of the uterus in endometriosis, and also in cases where there is a previous myomectomy where the bowel has gone and stuck there. Okay.
Yeah.
So what is the differentiator in these two? I mean, the total pathology, everything is different in both these adhesions.
See, that's a very unbelievable question actually. But see, try and understand. It depends on what you are trying to operate. Are you trying to operate endometriosis as a primary surgeon? That means, is that the first endometriosis surgery which you are doing? And your experience in that is going to be everything else will get separated apart from that nodule.
Yeah.
Correct?
Yeah.
This is grossly different as compared to the routine type of patients which we normally operate in Bangalore or Hyderabad or Bombay, where people have been operated once or twice before. People have done the adhesiolysis, which was any which way is going to happen, and reached the nodule and left it.
Yeah.
So what happens is the nodule stays as it is, but your surgical dissection goes and causes more adhesions at that site. Understanding? Which
Correct.
causes more altered anatomy. Correct. So when you try to dissect these type of adhesions, if you have ever noticed, what we normally try to do is we go to the lateral most part. That means we go to the vessels. We go to the topmost part, that is sacral promontory, because we believe that it is a pelvic disease. Now this is wrong. This is not to be considered when you are operating cecal endometriosis. Cecum is outside the pelvis. This is not to be considered when you are doing ileal endometriosis. That is outside the pelvis, right? You are talking of intrapelvic disease. So your basic concept is you need to create a window, which is a margin of window, which is free of the disease. Once you have that window free of the disease, you begin your dissection from there and approach the nodule, irrespective of primary surgery, secondary surgery, or tertiary surgery.
Okay, fine. Yeah, Aarti, do you have anything?
Jay, so just to summarize what you just mentioned, you said that one, earlier lesions have receptors and so they are more receptive to medication.
Correct.
And later endometriotic lesion become fibrotic and so they don't have receptors, and that
is because they don't have space, especially in deep places.
Right. So that's why no use of giving any of the medication available out there. That is one point you were driving across.
Correct.
Second thing is you mentioned about how to target this fibrosis. What is the therapeutic approach for targeting fibrosis? And you said surgery is the best
at the moment.
Yes, at the option. So what about, these anti-fibrotic agents out there in the market, and about just a little about NSAID. So these are the medical.
I use a very important word, ma'am. There is atypical fibrin, which is formed. And this atypical fibrin usually does not give enough, things to anti-fibrin agents. But remember one thing, ma'am. By the time you see it as a nodule, it has been present in that particular location since maybe 1 year, 2 years, whatever. Okay. And it has formed that much amount of fibrin. So your anti-fibrin agents are now going to prevent new defective fibrin formation in that region. It is not going to do anything to the fibrosis which has already occurred. And that is the concept. Once it has caused fibrosis, please go and remove it. You can't give. I operated somebody today, which we operated on Facebook Live, or sorry, on Insta Live. Patient is having ureteric endometriosis. Correct? This is pure fibrosis. Even if you give Dynogest, transrectal, transvaginal, you inject GnRH agonist inside that fibrin. Understanding, nothing will happen because there is no receptor for that. Okay. And that is the reason why she required a surgery. If you would have not operated her, she would have ended up with surgery plus nephrectomy. So at least today we saved her kidney, right? And this will then depend on the time taken between the identification of the disease and the surgical management at this moment.
Right. And this is also the reason why in scar endometriosis, people keep on giving Dynogest and, medical management. It will not work.
Absolutely. It simply does not work.
Right. Now, just one more point to drive across is the use of advanced imaging in looking at different signs of fibrosis, be it adhesions, be it bowel involvement, be it hypoechoic nodules in the posterior compartment or in the uterosacral ligament. So these are all telltale signs of fibrosis, and fibrosis means advanced disease. Advanced disease means you need to intervene surgically. That is another take-home.
Correct.
And one last point, Jay, when we are advising an MRI, MRI needs to be done with contrast so that you can differentiate between early active inflammatory lesions from fibrotic, more dense lesions.
More important usage for contrast in MRI is delineation of depth of invasion. Okay. And depth of invasion is a characteristic of endometriosis, which is going to be our next class, as to why in some places there is depth of invasion, why in some places there is no invasion, and why in some places it takes time for it to invade. All right. And but I will discuss that in great details maybe tomorrow or day after when we take the class on invasion in endometriosis. No, actually, Shilpa madam, when I said it was an unbelievable question, I really meant it, that it was a brilliant question, because asking that question meant that you are trying to differentiate between primary surgery and surgical adhesions of the primary surgery, which we have to look at in the secondary surgery. Okay.
Actually, it is not the point. The point was in endometriosis, the dissection is much more easier, especially when we have the nodule, because there is that much amount of space.
Agreed.
Okay, because
absolutely.
there is that nodule in between the posterior wall of the uterus and the bowel, unlike in adhesions, which is caused by the previous surgery.
Yeah, so, in previous surgery, everything will get adherence. The whole plane. Here, everything else is free, but that nodule. Right?
Yes. And you just have to, like how you say, take that bolt cut, take that bolt cut. I mean, if you are just taking that bolt cut, I mean, you are done. So why that should that?
You know why we use the word bold there, madam?
Bold.
Bold, not gold. Gold is what you use. Why do we use the word bold cut? The reason why we call it bold cut is because you are supposed to cut through fibrotic tissue.
Yes.
And that is the reason why you need a bold cut. Now, when people try and talk of cold cut in the same thing, that is when they don't understand the concept that it is fibrin. And we have this beautiful debates in some of the endoscopy debates that, do you use scissors or do you use electric current over this tissue? Okay, guys, it is fibrin. Even if you dance on the tissue, there is going to be no electric current which is going to spread through that tissue, right? So you use whatever electric current or you use no electric current. As long as you are cutting through fibrin, there is no difference, correct? And that is a very flawed debate.
Yeah.
The debate should be, should you use electric current over tissue or should you use cold knife over tissue? If you are cutting a nodule, you can just cut it with scalpel, scissor, whatever, monopolar, bipolar, it will just cut.
Yeah.
Right?
I agree on this.
Yeah.
Yeah, sure. Thank you so much. Thank you. It was a good one. Thank you for.
Jay, I have one more comment, Shilpa.
Yes.
See, when there is fibrosis in the ovary, it affects the ovarian reserve and causes subfertility. And when there is fibrosis in the posterior compartment, when there is DIE, it affects the sensory nerves. So these are the patients who are going to complain of chronic pelvic pain. So again, that is a telltale sign when the patient is complaining.
No, ma'am.
They are having
little difficult to answer that. I would answer it in this manner. Anytime when there is peritoneal involvement, it may end up mimicking any sort of chronic pelvic pain. Any form of peritoneal involvement, right? You will have so many patients who are going to complain of vague chronic pelvic pain post myomectomy. That is due to peritoneal fibrosis surrounding the uterus. That has got nothing to do with endometriosis. So basically, once the peritoneal irritation starts to kick in, either due to active disease or fibrosis causing nerve impingement, patients will experience chronic pelvic pain, which is a very important differential for endometriosis.
Right. Okay. So I think we can conclude the session, Shilpa.
Yeah.
Thank you so much. It was
Thanks.
wonderful for the detailed